What is effective patient education? Patient education is a challenge for health professionals, especially for students and novice clinicians. It's a big part of our patient consultation, and it can get pretty overwhelming, especially with thinking about where to focus our time and attention when there's often so much to say. So I want to share some key ways in which we can make patient education more effective and be more confident in how we deliver it. Firstly, we all know that we can't bombard someone with information, as it's just simply not remembered. So this takes pressure off me to try and do all of the things on day one. I can think strategically about where I might focus on the first day and over perhaps a number of consultations. We also know that patient beliefs don't just change overnight. People aren't going to be told something about their back pain, for example, and just suddenly shift their ingrained beliefs that they've held for years. So here we see that just as it takes time and gradual loading to change other health outcomes like strength or fitness, changing someone's knowledge, skills, behaviours or beliefs through patient education takes time too. Firstly, let's look at how adults best learn. Patients come with their own unique knowledge and experiences, so what we are focusing on needs to relate directly to what they are experiencing. This means patient education needs to be relevant to the person in front of us, so no generic information. The other big one is that adults learn best when they can work things out for themselves. Getting their input and working with them to come up with solutions can be really powerful. Before we look at what we should do, let's look at what doesn't help in patient education. One issue we often see is making assumptions about what the patient knows or wants to know. Where we might have an interest in anatomy and biomechanics, that doesn't necessarily mean these matter to the patient in front of us. Scare tactics or alerting the patient don't work well either. Scaring people into behaviour change just simply doesn't work well at all, and no one learns well when they're afraid. If what your patient takes away from your consultation is all the things that are wrong with them, we haven't really done well. Labels like wear and tear, degeneration, collapse, weak core, out of alignment can all be really alarming. And lastly, a mistake we often make is that we don't build on patient education over time. So we try and give all the information on day one, but then don't build on it. So we often fail to see really meaningful, long-term change in someone's knowledge or behaviour. So let's look at what we can do in practice. One of the most effective ways in which to prioritise where to go with our patient education is to ask some important questions in your patient interview. We call this assessing the patient's learning needs. Questions such as, can you tell me about what you understand is going on with your back? Or what have you previously been told? Or even, why do you think it's not improving? These questions can give us a baseline for where our patient's knowledge and understanding is, so that we know where to start. Questions such as, do you have anything in particular that you're concerned about? Or what are you hoping to find out about today? These questions are really specific, but they reveal so much. Just like we wouldn't start prescribing a strengthening program without measuring someone's strength first, we can't really consider where or how to deliver our patient education if we don't know what matters to the patient. So think about using your patient interview to better understand what your patient knows and what matters to them, so that your patient education can be more tailored to the person in front of you, and for you, easier to prioritise. These two skills are so helpful when we're delivering patient education. They allow us to break things down into digestible parts and help ensure patients not only understand the information we're providing, but they're more able to retain this information. So what's signposting? Signposting is using moments during your patient education that help structure the information that you're giving. So let's say you've got 4 or 5 things that you've prioritised. One might be addressing the patient's concerns. The others might be talking about the contributing factors, their diagnosis and prognosis, and the plan for management, as well as a plan for return to work. There's so much here to cover. Signposting can be used at the beginning and in between each topic to break up the information and check in with your patient. So at the beginning, we might say, let's have a talk now about some of those concerns that you're having. We can then talk through what's going on with your back, what's contributing to it, and what to expect over time. We can then work on a plan for managing your back pain and a plan to make sure you can get back to work as soon as possible. By doing this at the beginning of my patient education, it allows the patient to see the structure of what's to come. We can then signpost and check in after each of these parts. Now, summarising is a powerful tool and an important skill in our patient education. We can summarise information as we go, or summarise information at the end of the patient education, or even more helpful, at the end of our consultation. This allows us to check in with the patient about those key takeaway things we want them to remember and clarify anything further that might be needed. This is a great time too to write things down for the patient, maybe some key points or strategies to help with retention. Now, I won't go into the teach back method, but in part 3 of our patient education video series, we'll talk through it and how you can use it in practice. So when you're thinking about where to go with patient education and what to prioritise, remember these helpful principles. Patient education should take into account what my patient knows and their understanding and their concerns. Address patient concerns on day one. This is what has brought the patient to us. Avoid scare tactics. Unhelpful labels may contribute to unhelpful beliefs. And patient education is a gradual process, just like any of our other interventions. Set some goals around patient education and look to build on it carefully over time.